problem with the national media stuff is it's always around deaths, and I spend my
This is one of the questions I wanted to ask you.
really important one because so the conversation I was having with this guy from Morning Live on BBC, so they're doing a thing on Monday,
Yeah.
and I was sort of saying, it's really important because they were talking about restaurants and they're saying, we're trying to keep people safe in restaurants. And I said, one of the key messages is it's really important to go out to eat with your family and your friends, and to find ways to enable that and not sort of just scare people into thinking it's too dangerous to go out to eat. Which is the tone that they often get when your starting point is some horrible story.
Do you go by doctor or professor?
Professor, but just call me Adam.
Adam. Okay.
Yeah, I'm not funny that
Because
way.
I see it in both ways. So I
Yeah.
don't,
Yeah, it's funny actually because my original social media handle was Doctor, and then I was made a professor in 2020, and somebody said, "Oh, it's just too much trouble to change your handle," and I thought, you know what, whatever. So I just now confuse everybody, and they don't know what to call me.
Adam, welcome to Behind the Allergy. Thank you for coming.
Thank you for having me here.
I'd like to dive into you, especially when you were younger. Did you have an inkling that you would go into a medical profession? Did your parents, your family have an inkling that you would help people? Or was it something that was a surprise to you?
I'd love to say that I had a vocation because I was always very jealous of people that had one. I had a colleague who is now a very eminent orthopaedic surgeon, and we were at nursery together and primary school and secondary school, so I knew him his whole childhood. When we were 4 or 5, he was using scissors to cut up his teddies and sew them back together again. And when we're in the very early stages of secondary school, and I don't think they do this anymore, you get to dissect a rat. Pretty gruesome. I remember the whole class were made to finish what we were doing, and we all had to walk past this kid's rat because it was a work of art. This dissection, it was so beautifully done. I mean, it was remarkable, and we must have been 12 maybe. So this is somebody who absolutely knew what he wanted to do and went through with it and has very much achieved that goal. I can remember I must have been 16 or 17, and we had a school careers fair. And I remember my mother saying to me as we were walking around all the rooms, and they had a room for marketing and a room for law and a room for medicine. And she said, "Oh, why don't you go and have a listen to the talk about medicine?" And I remember saying to her, I said, "I'm not really interested in that." And that was at 16 or 17, so somewhere between then and what must have been about 9 months later, I applied to medical school. So I can't remember any sort of particular epiphany where I suddenly decided I wanted to do this. But I have to say there was never a moment from when I started that I didn't think, "Oh, I like this."
Yeah.
It is a remarkable and joyous profession to be in. It really is. And of course it has its very desperately sad moments, etc. But I think the one thing I do recall always wanting for my career is to not do something boring, and to do something that would really not just challenge me, but where there was I guess a little bit of drama, where stuff happened. And I remember having a moment during the course of training. There's a point where there's a little bit of a gap when you go from this has all changed now, what used to be a senior house officer to a registrar. You apply for a 5-year training program that leads you up to consultancy, but there's a gap when you finish your last senior house job of about 2 months. People do lots of different things, and I remember having this conversation with people about saying, "Do you know what, I just need to get out of my system this idea that maybe I don't want to be a doctor for the rest of my life." Maybe because so many people, when I look back to my school, there were 12 of us in my biology class in 6th form who did medicine. And from my last count, I think there's only 2 of us who have any connection to the NHS anymore. They've either gone out of medicine, moved overseas. There's this remarkable level of attrition of people who you always assume. I went to medical school thinking, well, I'll obviously be a doctor then. Whereas actually lots of people come out of medical school and go off and do a whole range of different things. So I really wanted to get out of my system. Is is this definitely what I want to do? Because now I'm starting this 5-year training program that then leads to a consultant post. That's sort of it. I need to get out now because I'm still young enough to go and do something else if I want to. So I went to work. This was the year 2000. So I went to work for what was very much in vogue at the time, which was a internet startup company.
Yeah.
And I went to one of two. There were two sort of websites and communities that were being set up for doctors, and at the time no one knew which was going to be the big one, and I went to the other one. There's now something called Doctors Net, which is very big and has got hundreds of thousands of members, and it was the other ones that no one would have heard of because it never really came to anything. But I went to work for them for a couple of months, and I remember it was sitting at a desk in front of a computer, and it was quite interesting. But I remember speaking to my wife on the phone and sort of saying, nothing really happens here. You sort of just sit at a desk in front of a computer. There's, that's sort of it. And it was such a stark comparison to life as a junior paediatrician, where you didn't know what was going to get thrown at you from one day to the next. It was a fast pace, and of course, that said, there's very little joy at 4 a.m. when you're on call, and this is the olden days where we used to go to work on a Friday morning and leave on a Monday afternoon. There were absolute shifts that are so just incomprehensible that we worked in the way that we did. The length of the hours, there was no sort of 13-hour shift and then you had to go home. No European Working Time Directive. It was brutal, but you never felt that you were bored. There was always that sense of something going on at work, which I clearly really enjoyed. Although that said, I also recognised that it wasn't particularly sustainable. And when I looked at colleagues who were going into, a career in intensive care or one of these very high acuity specialties where there's a lot of sick people all the time and you're going to be up at night a lot, and I could see, okay, this is going to wear thin once I'm out my 20s, and I'm not going to appreciate being in my 50s, being woken up at 3 a.m. So I really wanted to go down a route that got the benefits of being in an area where you felt there was a lot going on, that you could genuinely add value to people's lives, help people, but maybe during office hours more than the middle of the night.
Yeah. And so then you've said before that you were always interested in pediatrics and saw that the patients that you did see had a lot of them had allergic conditions, whether it be eczema or food allergies, and you thought, this is a field that I could go into, a specialized field, and you're not going to be in the hospital being woken up, early in the morning.
Absolutely.
But you started off in neuroscience.
Well, I did my degree, and so during the course of my medical degree, I did my third year where you do a sort of intercalated BSc. I did it in neuroscience. It just seemed interesting at the time, although I'm embarrassed to say I don't think I took it further in any way beyond that year. It was a really interesting year, but I think it was at a time where I didn't really have a clear interest in what direction I wanted to go within medicine. I think I was clear I wanted to be a doctor. But beyond that, I wasn't really sure. And look, it was a lovely opportunity with, the faculty were just out of this world. I mean, just, a stellar faculty. It's like, why would you not, do neuroscience with these people? But I think really what I found is that once I qualified, and then of course once you qualify, you get this much, much broader exposure to a whole range of different things as you do your first year or two, where you're doing a surgical house job, a medical house job, and you see all the different specialties and all the options open to you, and you start meeting lots of people with lots of different interests and going into different areas. You meet the more senior people, and you start looking to see, who do I aspire to be like, who do I look at their job and think, oh, I would like to do that. And what I found actually quite quickly is that you can very broadly divide doctors up into those that children scare the life out of. You get a lot of doctors who say, the idea of dealing with a baby who can't tell you anything and can either just cry or not cry, and you just can't, often it's slightly rudely referred to as veterinary medicine. It's if your patient can't communicate anything meaningful to you, or the other doctors who I was very much aware that just didn't bother me at all. And actually I enjoyed the interaction with parents. I enjoyed the interactions you particularly can have with older kids once they start communicating. And I really enjoy that there was one of the things that comes out of doing these insane hours. I mean, you basically lived at the hospital in those days. I mean, you occasionally went home. Although, of course, your bosses would always tell you how easy you had it, because they would always tell you stories about how they had to ask permission to go for a haircut because they were only allowed half an hour out of the hospital. And, things certainly had been worse previously, but it was still
Back in my day, we walked barefoot.
exactly. It was a little bit like that. And, whilst it was tough, one of the things, and actually I think it's a sad loss that I think many of the current trainee doctors don't get, is the level of camaraderie that we had. Because when you're on what was called a firm, which was sort of the group of doctors that between you would cover that specialty in the hospital, we were all there all the time, pretty much. So you spent a lot of time with other people at your level. Whereas now, because the hours are much less, inevitably there will be one junior on, and then they go home and another junior one comes on, another junior one comes on after that. So I think we had a much more collegiate training, which was hugely, hugely influence you, because it's what gets you through the day to day, essentially. But there was a lot of comedy in hospitals. So, they always talk about the medical sense of humour, and yes, there is an element of that.
Dark.
And it is pretty dark. But, if you want to, if you get a group of people together and don't allow them to go home very often and keep them in an environment where people are sick and dying, that's what you're going to get. And I really enjoyed that part of training, and paediatrics was a pretty intense specialty to be in, because it could be pretty unrelenting. And some of the training jobs I did, and again, these were days where the staffing levels you have now, you could only dream about that. I mean, I must have been 27 or 28 and just started as a registrar level. And I was working at Luton and Dunstable, which is a very, very busy, large district general hospital with a huge catchment area. And once 5 o'clock came, everybody else went home. And I was essentially found myself in charge of a huge general paediatric ward. There'd be up to 50 kids, inpatient kids there. A regional neonatal intensive care, one of the largest and busiest A&E departments in the country, where literally anything could come in. And I mean, some of the things that came in through that A&E department were absolutely hair-raising. And it was you and a couple of juniors who were GP trainees, so not particularly experienced in paediatrics specifically, and your consultant at the end of the phone. And of course, there was a little bit of a culture of, you don't want to be driving your consultant up the wall and ringing them unnecessarily, because they're the guy that's going to be writing your reference. But it was a remarkable environment to train in, and of course it's the making of you as a doctor. And I think when I reflect with colleagues back at what life was like, and if I'm sure many people would have watched This Is Gonna Hurt, which is the Adam Kay story, and I've really surprised myself watching that, because I read the book and it really resonated, because this is a guy who trained exactly as I was training in actually on the similar circuit. He was doing obs and gynae, I was doing paediatrics, but it would have been similar hospitals. And they filmed the show itself at Northwick Park Hospital. I don't think they named it as that, but it was very clearly, for anyone that's been there, it was Northwick Park. And it was remarkably accurate in terms of the culture, a mentality and the way it was, and watching it thinking, wow, that it really was brutal, that existence.
You kind of forget about it as well. Like, I think if you go through trenches, like when you go through something harrowing or something really traumatic, in like builds you up, you kind of forget how you were then. Because I can remember some traumatic times in my life, and I kind of put that out of my mind, and I'm like, it wasn't that bad. And my mom is like, you were crying every day and you were so upset and you didn't want to get out of bed. I'm like, okay, maybe it was that bad, but you just feel like you get through it, and then that means that you can go on to fight another day. How do you keep that level of interest and positivity, really, when you have seen the darkest parts of the human world? How do you keep that life outside of medicine in order to have a life yourself?
I'm really, really clear on the answer to that question, and it's something I'm a huge advocate, and it's what we refer to in medicine as a portfolio career. It's not just doing the same thing all day every day, because I think that becomes wearing and you get burnt out. And I've seen this, I've seen this at different stages of my career, and there's often a point when you get a consultant post, and then there's about a point at 7 to 10 years where you see quite a lot of colleagues leaving, either changing hospitals, trying to change specialties, just doing some profound change in their career, because they sort of think, I can't just do this for another 25 years. Whereas one of the great things, and this was definitely one of the key attractions of going into allergy as a specialty, was as a tiny specialty, because there were so few people doing it, there were very, very clear opportunities in research and academia, in education, even around things like media, for example, because there were so few people you could ever ask about allergy stuff. And it just meant that the day-to-day became much more interesting, because you weren't just doing allergy clinics all day, every day, because, you'll run out of steam inevitably at some point. But instead, I was very lucky that I was able to be involved in research a day or so a week, set up an education academy that took about a day a week, as well as doing the clinics and all the other things alongside it. And firstly, you get the huge benefits of the synergy between those things, being able to be involved in cutting edge work that means that you're able to bring innovations, not just to your clinical practice, but also through the education side of things to a much wider audience to really affect change. But I think for me, what made a huge difference as well is my first consultant role was actually at a large teaching hospital with very, very ambitious aims around allergy that didn't actually have a paediatric allergy service. So we got to set it up essentially from scratch. So with close colleagues who had already developed really good relations with for my training positions, we were able to bring across an academic program that they led and has led to global changes in public health advice through the studies that they were doing. But alongside that, we're able to set up a brand new service. Now, that's an absolute once in a career opportunity, because normally you come into a service that's already established very much in along somebody else's vision, and you just have to adapt and then see where you can maybe mold it and develop it into what you think will be better. Whereas this was literally a blank piece of paper. We were having the conversations about where the walls were going to go in the department that was going to get built, recruit all the staff from scratch, and develop a vision of what a large-scale, comprehensive, genuinely tertiary, as in highly specialist allergy service would look like within an NHS context. And that was a hugely exciting journey, and it was one that I think we got to, certainly for myself, got to the point after about, it was a good 10 years before I was clear in my mind that I'd sort of taken this as far as I was able to take it, and that for me, my focus from that side of things would need to be on making sure that there was a really solid generation of trainees behind me who would be able to take that on. And I think of all the things that I think went well through that process, one thing we did, I think, really, really well was that succession planning, because the people that I was able to step aside for are just brilliant. Yeah. And they're the sort of they're the sort of doctors that I would want to take my child to see if they had severe allergies, and I think that's as good as you're going to get. But what's really important is that other people working with you have to have a sense that they can progress. And in fact, what I did with my own career at that point is moved away from being just focused on allergy, and I took on a role as a clinical director for a much larger part of the hospital that included lots of other specialties, which I found fascinating because, of course, you've got so much to learn by just working with other bubbles. Allergy is its own little bubble. Dermatology is a different bubble, likewise. Sexual health, rheumatology, genetics. And I got to look after all of these services, many of which were adult medicine rather than paediatrics. And that's a really good thing to do, because the cultures in paediatrics is quite distinct from the culture in adult medicine as well. But getting to learn from all of those. But one of the things that I saw is the very sometimes destructive energy that comes from somebody just staying put and not moving on. And people who have been a clinical lead, they've been head of a department for decades, and the guys who are coming up behind them are sort of thinking, well, I don't have a future here because I'm never going to be able to progress my career in this place. Whereas I firmly believe that you can only, a lot of these roles, they've got a 3 to 5 year shelf life, and that if you've not been able to solve whatever problems there were in 5 years, somebody else needs to have a go at them, because all you're going to do is keep trying the same things and it's not going to work. And actually, you're better off moving on to a different challenge and a different role and bringing what you've got to give to something else and letting somebody else have a go.
Yeah. And when you first started in paediatric allergy, I think 2006.
Yeah, well, that was my consultant role. So I started as a trainee in about 2002. Yeah.
And then to now.
Yeah.
Obviously, I'm a 90s baby, so I have dealt with allergies for over 30 years. But during the teen years to like mid-20s, I was kind of, this is what was given to me when I was a baby.
Yeah.
And I just lived my life. And then when I started my platform, I was like, okay, now I'm going to figure it out. But the medical advice is different as well than in the 90s.
Yeah.
Even in the early 2000s, it's different to what you say now, like what the medical advice is now. How have you found that the medical allergy life is different versus when you started till now, good or bad?
It's tempting sometimes to look back and think, yeah, things were broadly the same, but they just weren't.
No.
I mean, it's just night and day, the difference. And there's some things that haven't changed. I mean, I think our basic clinical model hasn't changed very much. We remain a predominantly outpatient specialty. We, certainly within the context of a specialist setting, we've been very good, I think, at digging our heels in and saying, no, you need a minimum of half an hour to have a conversation with a patient. And whereas you've seen that eroded horribly in general practice, and I've seen it happen in other specialties. You've got that pressure from the hospital and management to sort of say, you sure you can just see 10 patients rather than 8 patients? And there is, without doubt, a significant impact on the quality of what you deliver to everybody as soon as you start doing that. So that sort of model of, seeing the patient, getting their testing done, having a conversation with them afterwards, that hasn't changed much. But you're right, the advice is profoundly different. And our understanding has really, really come on leaps and bounds. And I often look at it as the two different approaches are that when I started in this, we had a very passive approach to allergies. We were good at getting diagnoses. We were good at helping people manage their comorbidities. So if you see kids with food allergies, they'll have eczema, they'll have asthma, they'll have significant rhinitis and hay fever. And we were good at supporting them and managing those things. But when it came to the allergies itself, once you knew what you're allergic to, it was sort of, this is what you're allergic to. You better avoid it carefully, know how to recognize and treat an allergic reaction when it happens. But let's all cross our fingers and hope when you come back in a couple of years, it's gone away. Which really, is so, not what you want to be doing as a doctor. You really want to be able to influence things and support people to, yes, manage their own conditions better, but also to change their underlying disease. That's really the aim that, we all want. It got perhaps even more frustrating at the beginning of our development of our knowledge around this when we were getting better at identifying the risk factors. So if I saw an infant who, and a very common presentation would be significant eczema in an infant with an egg allergy, we knew those kids had a really significant risk of going on to develop allergies that weren't going to go away like their egg allergy most likely would. Allergies to peanuts and tree nuts and sesame, allergies that would be with them for the rest of their lives. But I'm not sure whether it feels better to be able to say, okay, you've got an egg allergy, your child now has a 30% risk of developing these allergies, but guess what? We've absolutely no idea how you can influence that risk. We can just tell you that you've got it. So, we're just going to cross our fingers again and hope that that allergy doesn't develop. But soon after that, by having that better understanding of being able to identify these really high-risk kids, of course, that's exactly what you want to know for a research study, so that you then start saying, okay, let's think of a sensible intervention, find these super high-risk babies as soon as they present to our clinics, and then randomly divide them into a group where you do this intervention or you don't do this intervention and follow them up and see if it makes a difference. And essentially that's what led to the LEAP study. So led by Gideon Lack, who was the professor I trained under. He, enormous insight into the potential here, recognized that there were places in the world where you got lots of kids with eczema and egg allergy who didn't seem to develop peanut allergy, yet clearly in the UK, these kids had a very, very high risk of developing peanut allergy. So he was really trying to understand and develop the experiments that would prove the points, why this was happening, and then, of course, use that as a lever to stop it from happening. And that led to the LEAP study, so the Learning Early About Peanut study. So this started with him looking at populations in different parts of the world and showing that it seemed that infants who had peanut introduced very early into the diet seemed much less likely to develop peanut allergy, even though they had all the same risk factors.
Yeah.
So then, of course, the gold standard here is a randomized controlled trial. So the intervention was, let's find these high-risk babies with eczema and egg allergy, but half of them, let's start giving them peanut as a very early weaning food. And the other half follow what was then the government advice, which was essentially based on not evidence. It was more just expert opinion, which was, well, there's a lot more peanut allergy around, so let's just try and avoid peanuts in the babies. So the advice was, don't eat it when you're pregnant or breastfeeding, and don't give your baby any peanut to eat. And the outcome, I mean, was way beyond expectations. I mean, for if you've got experience at looking at clinical trials, you're always delighted when you find a statistically significant difference in an effect. You make an intervention and it leads to a change that you can't put down to chance. But often that will be still a relatively modest difference, but still that's great. And, if it allows you to identify a medicine or an intervention that means that 10% less people will have high blood pressure, fantastic, it's progress. Yeah. But this was so far above and beyond this. I mean, this was an effect where there was an 80% reduction in the risk of somebody developing a peanut allergy if they had that the peanut introduced early into their diet compared to the current advice. That's a once in a career that you come across, to be involved in research that shows such a profound effect, and very quickly led to a change in global health advice. That's really quite something to be involved in, and a huge testament to Gideon and George Dutoy, another colleague of mine, who were the guys who essentially led this work. And that whole understanding about early intervention, of course, has blown wide open a whole field of research around allergy prevention. Yeah. And that was really, really exciting to be part of. But then alongside that, there were really exciting things happening elsewhere. So 2004, so just as I was doing my training, there was the first sort of proof of principle study from Adam Brooks in Cambridge saying, look at what happens when we start giving peanut allergic kids small but increasing amounts of peanut. We can get them to the point they can eat a whole handful of peanuts. Where's that going to go? And of course, nothing happens in too much of a hurry. But in 2021, we get the first MHRA approved, NICE approved, NHS available treatment for peanut desensitization. So I've been really lucky that my career has gone alongside these two profound changes in allergy prevention, in allergy treatment. That means that what an allergy clinic appointment for me looks like now is a world away. And I mean, this is a sort of bit of a soapbox that in my other roles, I was previously president of the British Society for Allergy and Clinical Immunology. And my sort of message I was always trying to get across to my colleagues is we've got to move away from being a diagnostic specialty towards being a therapeutic specialty, where it's not about just telling somebody what they're allergic to and telling them to avoid it. There are so many developing and emerging and now existing options to treat these issues. And really, really carefully not getting swept away with that, inevitable, just sort of, normal human response of let's do it because we can. And remembering that actually these treatments aren't right for everybody. And just because you can doesn't mean you should. But actually what we've really got to start doing, and I think this is for me one of the huge challenges, is the complexity of managing food allergy is so much more, in a good way, because we've got so many options. But how do you now, in that same envelope of time and, unfortunately in the NHS, that same envelope of finance as well, if anything, a shrinking financial envelope in the NHS, get the right people to the right options?
Yeah.
Because it was, when it was just saying, look, you're going to have to avoid it, but go and have a half-hour appointment with our paediatric dietitian next door, and she will go into real detail with you about reading labels and that avoidance. It's not as simple as that now. Now it's, well, actually, we've got to think about all the ways that we can prevent further allergies developing and what that looks like. We've got to think about, is there a role for oral immunotherapy for your food allergies? But actually maybe there's a role for a biologic, so one of these injectable medicines to enable that to happen, or just using it on its own. Or what about sublingual immunotherapy, or soon we'll have epicutaneous immunotherapy? This is really complicated, and there's now a huge focus on what we often refer to as shared decision making, essentially personalized medicine, which we've been talking about or hearing about for 20 years, but is now really landing in pediatric allergy, because every child, with not just their own different medical issues and whether they've got asthma or eczema, what food allergies they've got and how many they've got and the severity of them and all of that, but that family's personal experiences, priorities, desires, wants, etc. You've got to bring all of that in order to get a truly bespoke management plan that is the best for that child.
Yeah, it's not only the person with the allergies that are affected, and
Oh
I
no.
think so many people think that, and it's not true. I definitely think I was born too early because, even 10 years too
Yeah.
early, because, sometimes I find that when I moved out of pediatrics, people stopped caring. Every single year I was doing blood tests, I was doing skin prick tests, I was seeing my allergist 3 times a year.
Yeah.
And then when I moved out of pediatrics,
I know, it's a
I
culture
spent
shock,
10
isn't it?
years without, doing that. And things changed completely. Hormones changed. So like everything changed for me. And I just went on this trajectory of just thinking what my child doctor has told me, rather than who am I now as a teenager or in my early 20s. And so that's a bit hard as well. And I think so many times, like now, because there's so much new science, you don't see what goes on underneath. Like you don't see all the doctors doing all these trials and these tests. It takes years to do these things to make a medical discovery.
Yeah.
Because, you have to, especially trials with children, you have to wait till they grow up to figure out whether it worked or not. And then I just go, oh, well, if that had been done 10 years ago, maybe I would have not had all of these allergies and maybe I would have been fine. I didn't even realize, what my nose thing, like I have rhinitis or something. I had no idea, because they just was like, yeah, this is what happens. You have hay fever all year round. That's it. And so I've just grew up like that my whole life. And now I'm learning more because the doctors are learning more. But I feel like I have to advocate for myself more than they're going, hey, let's help you now as an adult.
There's a lot. I mean, look, a lot of people say, often the parents of the kids I'm seeing will say, oh, I had all of these issues and I wish, I was born 20 years. And I always say to them, do you know what? I'm sure your child will also say, I wish I was born 20 years later, because the next generation will have way better stuff than we've got. And thankfully, there is a continuous evolution. But stuff, it does take time. And I've got a series of slides when I talk about desensitization oral immunotherapy to peanut that starts with this sort of 2004 study saying, we've demonstrated this on 9 children and shown a really, really clear effect. And then, of course, there's all these media headlines that go with it saying in 3 years we'll have a cure for peanut allergy. And I've got sort of these series of slides of media clippings every 3 years saying in 3 years we'll have this cure. And of course, there's in 2017, there's an article saying in 3 years we'll have a cure for peanut allergy. It's like, I'm sure you said that in 2004. And, these things just do take time. But in a way, that's good, because it means it's being done carefully and rigorously. If the minute somebody did a small proof of principle study, it just got rolled out globally, chaos would reign and bad things would happen. And it's first do no harm. You've got to get these things right, and they do need very careful and slow over time. Very, very, very careful consideration because of the law of unintended consequences. But I mean, you're absolutely right. There is a very different culture within pediatric and adult medicine. The people in allergy feel that very, very acutely. They go from having this sort of, wraparound, and I'd love to say it's the wraparound it should be, but it's we don't provide anything like the service we should for our patients. There's just no capacity to do that because of the volume of patients. But it feels much more the case when you get into adult medicine, where it's very much not, we'll see you again in a year to check how you're getting on. It's basically, we won't see you unless there is a specific problem. And that's never great when you're trying to focus on prevention, because you're not going to be doing any prevention if you're only seeing people reactively when they're unwell. And there is a remarkable disparity between the number of specialist allergists in the UK compared to any other developed healthcare economy in the world. I mean, it's not a little bit different. I remember, I've been involved in sort of the politics of this for some years. And when you start talking to colleagues in the US and you realise that, the UK with a population of 65 million or something, there's less allergists in the UK than there are in Denver. It's sort of like, how do you get your head around that?
That's crazy.
And you speak to colleagues in France and Germany where there's 1,500, 2,000 paediatric allergists compared to, probably, 30 or 40 in the UK. Again, the clinical model is different. So if you've got allergy issues, you will often go to a primary care paediatric allergist in those countries. So you won't go to your GP, you'll go straight to, and there's a downside of that self-selection. GPs are a phenomenal gateway, and a lot of parents will get it wrong and they'll put down whatever their children's issues are to allergy when it's nothing to do with allergy at all. And so it's not very efficient to be deciding yourself, I think my child's problem is an allergy issue and that's why they're getting tummy aches. They would, our system, I think, works well for things like that. You'll see a GP, they'll do an overall, holistic step back assessment thinking, okay, if you need to see a specialist, it's probably this one, as opposed to leaving that to the parents. But the downside here, of course, is that if you go to a GP and they think, oh, you really need to see an allergy doctor, it's not really many to go and see. That's the problem. The waiting lists are back to where they were when I started, 20 years ago. We're back to the sort of hearing stories about waiting a year or two. If you're in Northern Ireland, I mean, you just awful stories because there's so little service provision. There are now, I think we've gone from being uniformly offering very poor provision to now in a situation where the biggest challenge is the inconsistency across the UK. Actually, you've got, we'd like to think parts of the southeast where, you can be 2 miles from King's College where they've got a really good paediatric allergy service, a couple of miles away from Guy's and St Thomas's, really good specialist service, etc. Or you can be in the southwest, or you can be in Scotland or Northern Ireland where there's just barely any provision at all. And we start getting to the situation where you get what I've often referred to as sort of first and second class allergy citizens, kids who purely by virtue of where they happen to have been born will get access to tertiary specialists offering a whole range of allergy prevention methods, access to clinical trials, access to desensitization treatments, whereas another child with identical problems born somewhere where you just aren't anywhere near those services, and then it's all downhill from there, because if you don't get access to the prevention opportunities, you're just going to get more and more allergies and more things going on, and they'll be less well controlled. And so because of the nature of allergy, the way that all of these different things impact on each other, the worse your eczema is, the more likely you are to get food allergies. The worse control your asthma is, the more likely you are to have severe reactions to the foods you're allergic to. The worse your rhinitis and hay fever is, the more it's going to impact on your asthma. Because of all these things interact, you end up seeing patients, and I see this in my private clinics, where people come from a long way away, and you think, how have you got this far? How have you been left in 21st century Britain to be in this state with, really poor eczema control, asthma control, and your whole life is so dominated by these undertreated allergic conditions? It's really desperate.
It's sad.
Yeah.
You mentioned as well that you do a lot of media work. I wonder how you feel personally when you have to discuss an allergic death, a reaction, or when you see people spreading misinformation on widespread media. Media that will go to these places where, they're not giving great medical advice, and they're seeing that on TV, and it's misinformation, it's laughing about allergies and not taking them seriously. And then you are somewhat a spokesperson for allergies right
Yeah.
now. How does that play on you mentally? Because even with me in social media, I find it hard, and I guess I live with the allergies, but I do find that hard to have to be reminded constantly of the consequences, but also reminded of how some of the public, I say most, but some of the public do not care and do not take it seriously.
Yeah.
How do you manage that, knowing what you know?
Yeah. It's tricky. I mean, I think we all, this is something I think comes with, life experience, remembering that what's important to you just isn't necessarily important to most people. And this is not in any way specific to allergy, whatever it is, whatever it's a political issue or a awareness issue or a disease issue or anything else. At the end of the day, most people, for good reasons, are mainly focused on what affects them. And so they're just not going to worry about anything else. And yes, there'll be a passing interest, but that's all all you're going to get. And that makes it a little frustrating because it feels with media that whilst we've definitely come a long way, and I think a lot of the credit for that goes to the Laperouse family, from massively, there was a sea change around the case of Natasha Laperouse around media management. It pretty much everything prior to that felt incredibly superficial. So we'd always grab with two hands any opportunity to get on the telly to talk about allergies. But you always used to get asked the same slightly painful questions. Is it a passing fashion and things like that. And I remember that my first ever tweet, and this must be a good 15 years ago, was I'd just been on, I think, BBC Breakfast, and they'd asked me, there seems to be so much allergy around. Is it just a passing fashion? And it's like, how can you ask that on national TV? That's such an offensive question and such an offensive way of framing, that issue. And I remember tweeting saying, do you think there'll ever be a time where I can talk about allergy and not be asked these ridiculous questions? And things have come on, and I think I draw a lot of comfort from the fact that we're definitely past that. That actually we're now able to go on and sort of assume a little bit of basic knowledge and go past that superficiality, which is what I'm really, really keen to do, because I think there's so many important issues that would be great to really flesh out more in a more public setting. But then also not forgetting that there are those fundamental key messages that just aren't out there yet. The importance of carrying your adrenaline, knowing that it's a safe medicine that you can that you should use early in the case of a reaction. And of course you get recurrent, very sobering reminders every time there's an allergy death and the subsequent inquest, and then there's these what come out of those inquests is the coroner will write a prevention of future deaths. And I've had conversations with coroners when they've said, one coroner said to me, he said, every time I see you, you're telling me the same things. And you realise, it comes down to the same messages about making sure you've got access to adrenaline, that you know when to use it. But I think one of the challenges is that a very significant proportion of the media coverage is through the lens of a tragedy. But that's not the day-to-day life of the overwhelming majority. I mean, thank God these things are incredibly rare. And there's data from Imperial College showing that if you've got food allergy, you are still more likely to be murdered than you are to die of your food allergy. Now, it's difficult, I'm not going to, I was about to say I'm not going to go on the telly and say that, and here I am on a podcast saying it. But, it's, because what you absolutely don't want to be seen to do, especially when you only get those few small seconds to talk to everybody, you don't want to minimize allergies because it is a life-threatening condition. But likewise, I don't want my patients going around not traveling, going to restaurants, living their lives to their full potential because they think they're going to die, when actually, if you put the risk in context, they're actually far more at risk putting their child in the back seat of their car than they are from, having their food allergies. We still need to get those key messages out, but we have to balance that with not minimizing the risk in front of the whole community. Because when you go to you go on the telly and say something that sort of says, no, these deaths are desperately rare and, they're overstated, etc., you're going to get everybody saying, oh, why are we worrying about them then?
Yeah. You're talking to the public as well as the community.
Exactly.
And so you have to be really careful. And I do think as well, like, it's why I find I've always wanted to say, I want to go on the telly and say, hey, look, I live a full life. I fly 4 or 5 times a year. I travel by car, I go to school. I work in a house that has nuts around me. Like, I'm living a normal life, but that's not newsworthy.
Yeah, no, I was going to say, it's not going to make great telly.
Because when you're like, hey, I'm happy, it's not going to make great telly. And it's hard because I want to share to more people, like, it's okay. But I do rely on the public. I do rely on them being aware. I do rely on them hearing stories of serious, what could happen to me, and then them taking me seriously. So, like, those kinds of messages I need for the public. but they're not helpful for the community. So it's like really hard to make that balance.
Yeah.
What is the hardest part of your job, do you think?
I think I think there's two answers to that. So I think on one level, emotionally, the hardest bit is seeing families who have just been so desperately let down. And then there's always a challenge of, do you tell them how desperately they've been let down? Because I'm not sure that's always overly helpful either. But I've actually got a document on my desktop that I just add the names of patients just so I can remind myself, so I can go back to their records. I've got a terrible memory for names of the worst cases I see, of where I believe that sort of, the system has essentially harmed that child. Cases where they've just been left, and this has happened more since COVID. I saw a patient yesterday, and the child just had horrible eczema that was completely undertreated, and they're just not being given any decent advice. And again, they'd come from a part of the country where we know there's a complete lack of service provision. But their story of how they're showing up in A&E because they're desperate, because they're saying the life isn't sustainable with really, really awful eczema in this this poor infant who's just not been properly supported, and they'll be sent a virtual appointment to have a telephone call with a dermatologist in 6 months. And it's like, on what level is that? Where in the world is that acceptable?
Yeah.
And I think, unfortunately, as Brits, we're a little, sometimes I think maybe we're a little bit too good at lighting down over that, and not just saying this is just not acceptable, and the healthcare system needs to do better. And of course, what happens is they then go and look for advice elsewhere. And I see so much of this. And classic example was the case yesterday. They didn't get properly supported by a dermatologist. I'm sorry, a dermatologist cannot diagnose a skin condition on a telephone call. So it just makes no sense. But they then spoke to a health visitor who said, well, I don't really know what to advise you in terms of skin management, so why don't you cut milk and egg out of your diet? It's like, well, how is that helpful? You're now making their life even harder. You're putting this child at additional risk of developing allergies by excluding stuff that there's not a problem with. And it's like, the system just doesn't work like this. So that's really hard. And I'd love to say I see this less and less, but I think I'm seeing it more. And there's no doubt that when I start 2003, I remember when I first started at St Mary's in London, the waiting list to be seen in the allergy clinic was a year. And of course, you'd see patients who basically they'd either sorted it out themselves, or it had got sometimes it just gone away. Literally they'd grown out their allergies by the time they were being seen. But I'm now starting to hear again that we're almost at that point, not in the big centres. Actually, the waiting times are much better, but it's not been a progressive improvement over time in the way that you would sort of hope things would be getting. So that's really difficult. I think the other thing on a professional level, find me the professional that doesn't say the same thing. It's time management. There's so much to do. And it's really hard when you see there's so many things where you think we could really make things better if we could just do X, Y, or Z, or if we could just, if I could just write to these people and let them know how they're impacting things without, they don't realise it, and they'd probably be absolutely on board with changing whatever they're doing in it. But you just don't have the capacity to, there's so many patients, there's so much research that needs doing, there's so much education that needs to happen, and I think this is one of the frustrations of being a small specialty, is there's so little capacity.
Yeah.
And I think this is something that, when you look to the US, in lots of ways, they do some things a lot better than we do. And certainly advocacy. You look at the scale of their patient charities, different order of magnitude to you've got patient charities there who are funding big research, tens of millions of pounds, whereas, the allergy charities here just don't have that clout. Some of them do, but unfortunately in allergy, we've not really got one that's really achieving the clout we'd like for them to be able to support research, advocate directly to government, and be listened to. We're still in a position, unfortunately, that we have to grovel a little bit for a little bit of ministerial time, if we're lucky, to be able to raise key issues. We're getting better at that, and I think we're being heard more, because I think we have some really, really good vocal advocates now, who are starting to sort of make sure that this is now on the agenda more, and as a consequence we're seeing far more in the media. So in that way things are getting better. But really, why should it have been so hard to just get the right people around a table and say, look, because this is where we need to improve things? Because for lots of these things, perfect example, allergy in schools. Yeah. Whenever you get the Department for Education and Department of Health and all those vested interests around the table, there's not really any resistance. They'll recognise that there's a problem, and a lot of the problems are solved just by having better guidance and signposting the right things. They aren't necessarily things that cost anything. And in fact, some of the interventions that would be really helpful will save loads of money. But you just need to get to these people.
Implementing the change, isn't it?
It's getting the right people to hear it, getting them to work together, getting people to work across agencies is really, really hard. Getting consistent messaging across, all of those things, it's really hard.
Do you manage allergies in your personal life?
No,
No.
I'm not an atopic person, although inevitably, because now everybody tells me, everyone I meet tells me what they're allergic to,
Sure.
as you can imagine. Although that said, as soon as you become a doctor, everybody tells you everything, and I mean, I remember a bit of a moment when I was at a wedding, and I mean, I was barely qualified, and I was in the reception area outside, and somebody walked out and said, "Why did that guy have his trousers down in front of you?" And it's literally people are taking. I've been doorstepped in the car park at the underground station of somebody saying, "Oh, I've seen you on the telly. Can I just ask you about my nose because it's really blocked up all the time?" And it's like, really? So no, in my extended, there's a fair amount of allergy. I've got a niece with multiple food allergies, and look, who hasn't got somebody in the family with hay fever? These conditions are so common that you almost think when you ask about family history and they start saying, well, great Uncle John had it. It's like, okay, we don't need to go that far because everybody's got a relative with hay fever. There's a lot of it about.
I always end my podcast with one question: is how is your mental health at the moment?
Goodness me, I don't think anyone's ever asked me that. I would say pretty good. Yeah. I think one of the great joys of growing older, because there aren't many, from my impression is just looking at colleagues and reflect on myself, is that you do get wiser as you get older, and you don't let things bother you in the way that they might before, and you're able to put things in the context of a bigger picture. And so I mean, I can look you in the eye and say I'm pretty happy.
Good. Well, thank you so much for coming on. I really loved hearing you talk and hearing more of your story that I didn't know before. So yeah, thank you so much.
No, thanks for having me on.
Wow, that was so nice.
Good. That's all right. Wow, that was very broad ranging, wasn't it?
Yeah, no, I just love to hear more about who you are and just more stories that you might not have told on other podcasts.
Yeah.
Or things like that, and more about you. But